A very good evening, everyone. Thank you so much for spending your Friday evening with us. I'd like to introduce Dr. Ryan, who's joined us for this webinar. I'd like to thank Dr. Ryan as well. Dr. Ryan Foley, he is trained in the USA. He's worked a number of years over there before returning back to his home country, that's Ireland. And he set up his own clinic over there where he specializes in treating musculoskeletal conditions. He has created IKN with a colleague, Dr. Kyle Paxton, with his colleague in the USA, and they teach to integrate neurology and guide us how to approach assessment and treatment of the anatomy. IKN is taught on every continent and is being taught over 40 countries. It's used by physiotherapists and other movement practitioners in all over the world. Thank you so much, Dr. Ryan, for this amazing webinar. Please, I think we can begin from here.
Perfect. Thank you very much.
You're most welcome.
Once again, thanks, guys, for sharing your Friday evening with us here to learn about the knee pain rehabilitation concepts. And thanks again for those of you who tuned in. I believe it was the week before last where we spoke about low back pain rehabilitation concepts. Now, we wanted to start off, so if you tuned in then, you'll see that this slide looks very familiar, because this slide here just kind of gives us a very brief insight into the overall kind of framework that we use to guide how we assess and how we treat the body. So at IKN, we look at the interaction between the nervous system, the neurology, the anatomy, and the environment. And one of the things here that might stand out to you, that might be different from most, neurological and anatomical frameworks, is that we consider the environment, because the environment is essentially the place that delivers force to our system. When we're moving, we're not moving in a very simple environment. Oftentimes, we're moving in a very dynamic environment. So when we're moving outside, the dynamic and changeable environment that we're moving in delivers and exposes us to constant forces and stressors that we're constantly having to deal with. So you can never consider how the nervous system and the anatomy interact without considering the environment, okay? Because when you look into nervous system research and you look at how our movement apparatus as a whole is organized, and I'd like to use this kind of skeletal image just as a representation of how unique our bodies are, but how similar they are in a way. Because if you look at people from the exterior, we all look very different from the exterior, but beneath the surface, we all have a very similar architecture, if you like. We all have a very similar structure, and there's a reason for that, because again, our body has been designed in a certain way, you can say, to allow us to handle stress and forces from the environment. And so as we move from distal to proximal, at IKN we use a very distal to proximal driven framework, because when you consider what parts of our anatomy are in direct contact with the external environments, if you consider that for a second, when you look at this skeletal arrangement, what portions of this skeleton is in direct contact with the environment? In direct contact now, that's actually interacting with the environment. And what you should consider is that it's the endpoints of the limb. Right, the limbs interact with the environment directly, but it's more so the hands and the feet that directly interact with the environment. And so, because these segments of our anatomy interact directly with the environment, these segments are exposed to more external forces. Okay, and this is very, very important when we consider the knee, because when we consider the knee isn't the endpoint of the limb. The knee is one joint, you can say, proximal to the distal endpoint. So the foot and the ankle is the portion of the anatomy that is in direct contact, that's directly interacting with the external environment, and then the knee is more proximal to that. So the knee is not necessarily handling direct internal or direct external forces, but it's more so managing internal forces as a result or in response to how the foot is managing that force from the environment. And that's really, really important to consider when it comes to the knee, because not all knee issues are actually issues at the knee. Many times individuals will experience sensitivity. They'll experience maybe excessive stress in certain areas around the knee because there's a lack of load sharing across the entire lower limb as a whole. Okay, so within this webinar, we're going to talk about the importance of looking at the ankle and the foot. considering that within the context of the environment, but also considering the motion of the knee as well as the hip and the pelvis. Okay, so it's really, really important to look at these segments, how they interact, but looking at them as part of a global structure. And many times, again, I'm sure a lot of us already, we can appreciate that the knee will respond to what the ankle and the hip are doing in response to the environment and the forces that our limb is under. But can we actually integrate that understanding in a very sequential framework through the assessment and then into the treatment process? Because that's the one thing that we find at IKN is what practitioners struggle with mostly, is understanding, well, what do I do first, then what do I do second, and then what do I do as we progress through the treatment process? Obviously we need to look at how we can manage symptoms, but when it comes to restoring the capacity of the knee to be able to handle stress, very, very often the knee is handling too much stress or taking on too much workload. And we need to understand, well, how can we actually share that workload across the foot and the ankle and across the hip as well to take the load off the knee. Okay. And so that's just one example of why it's important to consider a distal to proximal approach, and considering what segments are directly interacting with the environment and what structures are more responding to the external forces, right, through internal forces. So the foot and the ankle is experiencing direct external forces, the knee and the hip and everything else proximal, even up into the pelvis, into the spine. They're responding to the internal forces that come from the foot and the ankle. We also need to consider what kind of strategies the individual is using to manage stress and manage that load. So when force comes from the environment, when our foot hits the ground, which is essentially a collision. When we walk, our foot's colliding with the ground. Ground reaction forces are being distributed through the lower limb, okay? And our body has certain ways that we can actually manage that load or respond to that load. And from a neurological standpoint, there's two main ways that our body will manage load or respond to load. We may produce force against that force, right? So we'll produce a motor output in response to the pressure and load acting on our body. So at the foot and the ankle, for example, that may be a case where we're plantar flexing into the ground. If we're plantar flexing into the environment, onto the ground, then we're producing force. Okay. Whereas if we're just decelerating force, we may be able to maintain that foot and ankle position closer towards dorsiflexion, but we're allowing for the plantar flexors to express more isometric activity, where we're just responding to the forces, right? Because if you're constantly fighting the ground, and you might see this a lot in clients that have limitations in dorsiflexion. If you have limitations in dorsiflexion, it's a potentially a situation where the individual is fighting the ground, they're fighting the forces when they shouldn't be. So they're expressing a lot of concentrically driven activity in the plantar flexors when they shouldn't. Okay, because if you're expressing a lot of concentric activity all the time in a muscle tissue, that's a strategy that you can't necessarily sustain for long periods of time. Okay, it's very good when we're trying to run, or if we're trying to sprint, or if we're trying to go up a staircase, or we're trying to move on an incline. But if when you're walking down the street, or if you're walking around your home on a level surface and you're fighting into the ground, you're constantly plantar flexing and producing force into the ground, then that may facilitate an environment, a local environment within that foot and ankle that may maintain a lot of tension, concentric tension. And in order to actually share forces across the limb as a whole, we want more isometric activity with more eccentric qualities. Okay, because when we have more isometric behavior of tissue and more eccentric behavior of tissue, it allows us to share forces over broader surface areas. Okay, and so that would be more of a force deceleration strategy. Okay, so these are kind of global strategies, global ways that the central nervous system interacts with our anatomy. So in order for our bodies to express more force deceleration strategies, we need to make sure that our joint segments and our muscles can actually work together and cooperate. If you think of it like an orchestra, for example, an orchestra or a symphony that produces really nice music doesn't necessarily come from one person doing all the work, right? It comes from every portion of that orchestra or that symphony being able to cooperate with each other. Okay, so if we can get everything along that lower limb able to cooperate with each other, then we can share those forces. But if you have an individual who has a lot of concentric tone and tension around the calf, for example, then that may not allow for forces to be shared very well, and that may lead to excessive stress being distributed through certain areas. And it could be a case where the knee starts to take on most of that stress in that scenario. So how might this impact the knee? One easy example to use is if we consider the dynamics of the muscles around the knee. Now, if you watch the last webinar that we did, we spoke about the importance of considering the nature of biarticular muscles versus monoarticular muscles. Muscles that cross two joints, which are biarticular muscles, two or more joints, and muscles that cross one joint only, monoarticular muscles. Now, when you look at the neuroscience and the biomechanical behavior of those different muscle tissues, biarticular muscles are biased towards more distributing load over broad areas. So, for example, if you look at the hamstrings, for example, the hamstrings will connect the pelvis to the tibia. So it crosses both the hip and the knee joints. And that allows us to share forces over those broader surface areas. Because when you look at let's look at the femur, for example. When you look at the joint organization of the femur versus the spine, for example, the femur doesn't look like the spine, right? And if it did look like the spine, I think we'd be in a lot of trouble in terms of how we would move, because, when the limb is actually taking on a lot of stress, if we had a leg like the spine, there would be a lot of instability, you can say, in that lower limb. Okay, so we need a joint organization across that limb that allows us to handle force as well. But because we don't have that segmentation across the femur like we do with the spine, we need certain muscle tissues with a certain behavior that will allow us to share that stress. Because the spine has segmentation, it can allow us to share stress across the spine very easily because of that sharing of that coupling of joint motion across the spine. So when you flex your spine, for example, it's the product of small motions across the entire spinal vertebrae, or the entire spinal column, and that's okay. That's fine, because the spine is not in direct contact with the environment. It doesn't deal with external loads. It typically deals with internal forces from the end point of the limb. So we need to consider that kind of behavior. But when you think of the most constant stressor that our bodies are always dealing with on a day-to-day basis, on a second-by-second basis, that I'm even dealing with right now, the most constant stressor that we're always dealing with is gravity. Gravity is a constant force that's always trying to pull us down to the ground. And so we need to organize our body in a certain way to be able to manage that gravity. So when you look at the anti-gravity muscles across the lower limb, for example, we have the quads in front with particular focus on the rectus femoris, which will cross the hip and the knee joint in front anteriorly. So let's say, for example, we have a client who has anterior knee pain, and we assess their limb, and they have limitations in knee flexion. Potentially, their system as a whole is using a very kind of concentrically dominant strategy through the quads, through the rectus femoris, to keep us upright against gravity, right? So it's putting too much concentric tone to keep us upright, but that doesn't allow us then to share forces across the entire lower limb. So if an individual has limitations in knee flexion, we need to consider if the anterior muscles of the thigh are able to express more isometric or eccentric behavior. Because if they can't express that kind of behavior, then potentially we're not going to get that nice coupling motion between the femur and the tibia. Right? We're going to speak about that, the importance of coupling between the femur and the tibia, in just a moment. But remember, a lot of concentric activity around specific tissues doesn't allow for forces to be shared. Because if you think about it, if you were to contract the quad, and what would happen at the knee if you contract the quad? You're going to get an extension of the knee. Now, if you extend the knee all the way, that's going to allow you to stay upright against gravity, right? But it does so at the expense of adaptability, right? So if you're locking out your knee into hyperextension, it keeps the knee very stable, but you don't want to walk down the street with hyperextended knees. You don't want to walk down the street with fully extended knees, because that doesn't allow for your lower limb to handle the collisions acting from the foot up through the lower limb. So while it might seem like a stable strategy, it does so at the expense of load sharing. It does so at the expense of adaptability. So it doesn't allow for forces to be shared across the knee, because all the forces will be going into the knee in that scenario when we move with a fully extended knee. So we need to understand how these strategies would play a role when we're actually walking in the real world and we're moving around in the real world environment. So what we need to do is we need to assess and treat key interactions, right? So the interactions that we're going to consider here from a knee pain standpoint is the interaction between the pelvis, the femur, the tibia, and the tibia, the foot, and the foot and the environment. We need to look at these general interactions. How is the pelvis going to cooperate with the femur? How is the femur going to cooperate with the tibia? How is the tibia going to cooperate with the foot? And how does the foot behave in relation to the environment, right? So we're obviously looking at the lower limb in this scenario here. And how might these interactions change under different conditions, right? So for example, if you're an individual where you're sprinting, right? If you're an athlete and you're running 100 meters, you might want a lot of concentric activity in your quads to push you forward, to produce force into the ground to push you forward. But if you're just walking down the street at a moderate pace, you probably don't want a huge amount of concentric activity in your quadriceps, right? Because that's a strategy that doesn't match the dynamics of the task, and that can potentially influence our ability to share forces and share stress across that lower limb. Okay, and this will become much easier to understand as we move into the next few slides. So we look at it from a global and a local standpoint, from an IKN standpoint. So when we look at the lower limb, for example, we need to understand what's happening on a neural level. How is the nervous system interacting with the lower limb? How are the muscles behaving? How are the joints behaving? And how does our attention change things? Okay, and we will speak about more so the neural, the muscular, and the joint behaviors. So like I said in the last slide, we take a very distal to proximal approach. So when someone presents to our clinic with a knee pain, we're looking at it from a standpoint, okay, is how is that knee behaving within the context of what's happening from distal to proximal? So straight away, we're looking at, how is the foot behaving? How is the foot interacting with the environment? How is the foot interacting with the tibia? How is the tibia interacting with the femur? How is the femur interacting with the pelvis? Because we ultimately want the client to walk outside the clinic, right? So when they come into our clinic, we have to recognize that humans will express certain movement behaviors, and mainly humans will walk into your clinic on their feet. They won't walk into your clinic on their knees or on their hips, right? They'll walk into your clinic on their feet. So we always want the distal tissues, the foot and the ankle segments, to express that capacity to handle stress well. Okay, the question, we always have to have questions going through our mind. Well, maybe the sensitivity or the discomfort around the knee, for example, is secondary to a poor capacity to handle stress and pressure at the foot and the ankle, and then maybe the knee is taking excessive pressure, for example. Okay, so globally, we're looking at the behavior of the entire lower limb. We're looking at how the biarticular tissues can actually handle stress well, because those biarticular tissues are going to be very important to distribute stress over broad surface areas. And then, like I said in the last slide, when we look at this interaction between different segments, we're looking at the interaction between the foot, the knee, the hip, and the pelvis on a neural, muscular, joint, and attentional level as well. And once we can understand, what are the general behaviors at those different interactions when the client does different things, then we can understand potentially what they need to actually allow for the limb to be able to share stress much more efficiently. Okay, so let's say, for example, if you have a client, who has pain not when they sit down, but when they transition from rest to moving. So when they transition from a seated position, let's say they've been sitting for 10 minutes, 15 minutes, and they have pain when they transition from seated to standing, and they kind of limp for a little bit. But potentially, when they were at rest, the tissues around the knee weren't able to down-regulate and relax. So maybe that quadricep was always expressing a lot of concentric activity, and it didn't give the knee a chance to actually relax and down-regulate. So there's still a lot of stress going into that knee, even when they were at rest. Okay, so what we need to do with that kind of scenario is we need to restore the capacity of the rectus femoris, the quadriceps, to unload that concentric activity and just restore that capacity of the tibia and the femur to couple from each other. And I know at the moment it might not make that much sense, but if you consider that scenario compared to a scenario where someone might be fine when they transition from rest to standing, but they might have more knee pain when they go for a long walk. So they might be fine for the first few minutes when they walk, but maybe kind of 30 minutes or an hour into their walk, that's maybe when they start to have that knee pain, and that starts to build up. So in that scenario, maybe it's a case where it's not where we need to kind of get a lot more coupling between the femur and the tibia to allow for stress to be shared, but we need to make sure that the foot and ankle tissues and the calves, for example, are able to handle that stress well, so that the knee doesn't take too much stress. So maybe in that scenario, and I'm just talking general here, maybe in that scenario, they were able to tolerate that pressure 30 minutes, 45 minutes into the walk. But after a while, the calf tissues, the foot and the ankle, lost the capacity to be able to handle that stress over that sustained period. And now the knee is taking that pressure. So they're only experiencing the pain at certain times. So that kind of behavior, symptomatic behavior, can tell you an awful lot about what kinds of things we might need to do to make sure that this individual doesn't continue to experience knee pain. So looking at the coupling behavior between the tibia and the femur, because the knee is not just a simple hinge joint. So when we typically, again, I've learned this in school as well, where you typically learn about the knee and we consider the knee as just a simple hinge joint where it bends and it flexes and extends. But within a sagittal plane motion, the knee needs to express the capacity to rotate very, very slightly. And that's secondary to the shape of the femoral condyle. So when you bend the knee, when you flex the knee, when you bring that heel closer to your glute, that tibia needs to be able to internally rotate. And that internal rotation allows for the knee to still flex, for the tibia to flex on the femur, and it also allows for the capacity to share forces across a broad surface area. Because imagine if you were walking around and that knee was only operating like a hinge joint, that wouldn't allow for a slight little bit of rotation between the femur and the tibia. Now, you only want a small bit, you don't want too much coupling, okay? Now, when you look into the research around why we have that capacity to rotate, and it's the same thing with the elbow. When you extend the elbow, the radius needs to be able to slightly, the forearm needs to be able to slightly rotate, and when you bend the elbow back, it needs to be able to rotate as well. The elbow doesn't operate like a hinge joint. If that were the case, then it would be very difficult to manipulate our hand with the environment. It's the same thing with the femur and the tibia. Now that coupling, that rotational coupling, serves as an error dampening mechanism. So when we have that coupling between the femur and the tibia, that slight coupling, that allows for stress when stress is distributed from the foot up through the limb. That rotation allows for that stress to be shared across a broader surface area. Whereas if it was a hinge joint, it wouldn't allow for that stress to be shared across a broad surface area. So that rotational coupling gives the knee a little bit of variability that it needs to respond to many different forces that run through the tibia and up through the limb from distal to proximal. And very, very often when we lose that rotational coupling, we tend to see things like this. You know, this is your classic kind of valgus moment at the knee. And many people see this as a bad thing that we want to try and correct. But what this does is it tells us that they're unable to allow for that coupling somewhere else. So the knee is trying to express that coupling excessively. Okay, and now we have to look at the hip and the ankle in a different way here, but we'll come back to this in just a second. So when you look at knee flexion is when is not just a simple bending and straightening of the knee, but it's a representation of how well the tibia internally rotates. And because the tibia internally rotates, I have a skeleton here I can show you quickly. Hopefully you can see this here. But when that tibia bends back the way, that tibia needs to be able to internally rotate to unload what's known as the screw home mechanism, right? I'm sure we all heard of the screw home mechanism. So when that knee extends, once it gets to about 20 degrees short of full knee extension, that's when that tibia will begin to externally rotate. And then relatively, the femur will be, if the tibia is externally rotating, relative to the the femur will be internally rotating. And when I flex my tibia, to flex the knee, to bend the knee, because my tibia is internally rotating, my femur is going to be relatively externally rotated. So many, many times, we see this a lot clinically, and we see a lot in our courses as well, is that when an individual lacks the capacity to bend the knee, when they have limitations in knee flexion, let's say they have pain around 90 degrees, many times it's because their tibia is still biased towards external rotation, and they're unable to fully unload or offload, you can say, that screw home mechanism. So they're starting in knee extension where their tibia is externally rotated. But in order to bend the knee, they need to internally rotate. But if they can't internally rotate, then they're not going to get that full flexion of the knee. So we can appreciate, well, maybe that's a joint issue. Maybe it could be a case where the quadricep muscles on the anterior portion of the thigh are expressing too much concentric behavior, because when they concentrically contract, we're going to see this knee extension, right? And when the knee extends, remember, the tibia externally rotates. So what if it's a case where the quadriceps can't unload their concentric behavior, and they don't fully allow the tibia to be able to internally rotate? So now you can see the effect of anterior tissues of the thigh, for example, and the type of behavior that they might express if they're always holding on to concentric activity because they're trying to fight gravity all the time. Then that may influence how the knee can move. Okay, right. So hopefully that makes a little bit of sense, and that means that we need to consider the muscle behavior, but also the joint behavior. And we may have to, obviously, from an IKN standpoint on our courses, we go through lots of manual strategies and movement-based strategies that we can do to restore that coupling behavior across the knee. Because many times, if you have somebody, for example, with anterior knee pain, very, very often it's a case where they're unable to rotate that tibia relative to the femur. And sometimes that might be excessive concentric tone. Sometimes that might be a lack of appropriate muscle behavior and contractile dynamics of the hamstrings in the back. Sometimes that might be the calves issue, right? So if the individual system can't allow for variability in how the muscles behave across that lower limb, then what might the individual do? They might just extend the knee, because that's a safer position, but it does so at the expense of adaptability. Okay. So when we consider, and this is important to consider in the context of that valgus. So a valgus movement of the knee is when the femur internally rotates and the tibia externally rotates. So we see that kind of gapping of the medial portion of the knee. But very, very often, what we see clinically an awful lot is that when the individual can't handle stress well through the foot, when the individuals don't have the necessary capacity to rotate the femur relative to the pelvis, then what they'll have to do, they'll have to excessively move the femur into internal rotation, right? Because when you move, when your foot hits the ground, you need a certain amount of internal rotation to share forces, right? Internal rotation is typically when we're decelerating forces. We have to internally rotate to decelerate. We externally rotate to produce forces, right? And sometimes it's easy to understand kind of how that's represented at the foot, where if you're trying to, produce force into the ground, what kind of representation are you going to see at the foot? Is your foot going to supinate, or is your foot going to pronate if you're actually putting force into the ground, right? Typically, your foot's going to supinate, where it becomes more of a rigid lever. But when the foot supinates, that's an external rotation of the foot. The arch lifts, that's an external rotation. So that's a representation of external rotation. Whereas when we decelerate, we need to have a certain amount of internal rotation at the foot to allow for forces to be shared proximally from distal to proximal. So when an individual doesn't have those movements, they have to excessively move at the pelvis and the femur. So what you're seeing there with dynamic valgus is the pelvis kind of excessively moving towards the left to drag that femur into internal rotation. And then we have a foot that's that maybe can't kind of maintain contact with the ground. And so we see the lateral portion of the foot lift off the ground because maybe we can't handle stress there. So we see this knee get dragged inwards because the individual can't share forces very well. Okay, and obviously you'll see this very often when someone maybe steps off a step or a curb or lands from a small jump. And so it's really important to consider dynamic valgus like this, not as a bad thing, but think about what that means across the entire limb. Don't try to correct the valgus, but try to assess where the individual might be lacking movement, where might they be lacking other kind of coupling behavior to make sure that we can share that stress. Because the dynamic valgus is just a representation of the entire lower limb can cooperate very, very well. Okay. So let's move into muscular features. Now, when it comes to the muscles of the lower limb, generally when we think about it, and it's easy to consider this with almost every human, is that as we move from proximal to distal, we tend to have much less muscle mass. So when you look at the hips, for example, we tend to have a lot more meaty tissue, right? Through the glute, for example. The glute is a nice meaty tissue, versus when we go down towards the femur into the lower portion of the limb down around the foot, we don't have a lot of meaty muscle mass, right? We tend to have more tendons, more connective tissue, more passive tissue, right? And there's a very good reason for that, because if you imagine what it would be like to walk around with a foot that looks like your glute. It wouldn't be a very adaptable lower limb. It wouldn't be very easy to carry around a foot that looks like a glute, that has all the muscle tissue like a glute has, right? So that's why the distal portion of the limb has less muscle mass, but it has more tendinous tissue, is more connective tissue, is more passive tissue, because connective tissue and passive tissue serves as a buffer for stress. So when ground reaction forces impact our lower limb, that tendinous tissue allows us to dissipate that stress over broader surface areas. Okay, and that's really important to consider, because if we understand that, we can recognize how different muscles across that lower limb, from distal to proximal, will express a different architecture. Okay, and this might be a new concept for a lot of people, but it's one that we find very, very important to consider when we're trying to think about how we might want to treat an individual and what kind of exercises we might want to use when working with an individual. So it's easy to consider the glute, the hamstring, and the calf as representations of what we're talking about here. So when we look at the glute, for example, the muscle architecture will display more parallel fiber orientation. So you'll have much longer muscle fibers. This is a cadaver picture here. So when you look at the glute, for example, you can see these nice long muscle fibers, and the glute doesn't have very long tendons like the hamstrings or like the calf, for example. And there's a very good reason for that, because the glute is primarily more of a single joint muscle that crosses one muscle, and the glute is primarily designed to produce force. So when we're trying to produce a lot of force over a broad surface area, we need a meaty muscle, and we need long muscle fibers, so that glute can actually eccentrically lengthen and then concentrically contract. Yeah, so this is a question from Eduardo. So muscle features will help us understand if the knee is maybe taking on too much stress, because an individual may not be expressing the appropriate muscle features. So for example, I'm going to go through these muscle features quickly, and then I'll describe what I mean. So this glute will have much longer fiber lengths. So when we have a muscle with longer fiber lengths, or parallel muscle fiber lengths, that means that muscle is specialized for force production. It behaves more so by lengthening and shortening. Whereas when we look at the hamstring, for example, the hamstring, when you look at the fiber orientation, the fibers don't run from both attachments through long muscle fiber orientations. They tend to run at angles. They insert into the tendon at angles. And that means that the hamstrings don't necessarily go through a huge range of motion as we move. And so that means that this kind of tissue with a lot of tendinous components to it, with long tendons, that means that this tissue will behave better isometrically. That's what it's designed to behave as. It's designed to function best isometrically, right? Because in order for tendons to be able to lengthen and act as a buffer, they need the muscle to behave isometrically. So the muscle stays the same length and the tendon actually lengthens, right? So that's what happens in the foot and the ankle as well. When your foot hits the ground and your metatarsal heads contact the ground, the calves typically remain isometric, and it's the Achilles that actually lengthens and shortens. So the reason why this is important when it comes to the knee is that if we lose the capacity for these structures here, you can see the long tendons of the hamstring, you can see the fiber orientation of the calf where there's a central tendon as it moves into the Achilles, and the fibers run at an angle. That means that these muscle fibers aren't designed to move through large ranges of motion. That's why we have the hip with a huge amount of motion. When you look at the motion around the hip, we have a huge motion of the hip. But as we get further down into the knee and the ankle, we don't have as much range of motion like we do in the hip. So that's why we have longer muscle fibers. But this gives us an understanding of how we might need to treat these individuals, right? So if we have an individual, let's say with knee pain, and they have a lot of stress in the anterior portion of the knee, but their hamstring can't actually express good quality isometric contractions, then that may put a lot of stress on the knee, for example. It's the same thing with the calf. If the calf is unable to behave isometrically, to share forces over broad surface areas, then that may put a lot of stress on the knee. Okay? So really, really important to consider that kind of muscular behavior, right? As we move from distal to proximal, shorter fiber lengths distally. As we move proximally, we have longer fiber lengths, all right? So the muscles with shorter fiber lengths are more specialized for isometric behavior. The muscle fibers proximally with longer fiber lengths are more specialized for lengthening and shortening contractions. And this is something else that we see an awful lot clinically, is that, let's say, for example, you have a client with knee pain, and you look into their past injury history, and they have a history of ankle sprains. Very, very often what will happen there is that the individual will lose good quality isometric behavior of the calves, for example. If they lose good quality isometric behavior of the calves, then that might not create a very good quality environment distally for the foot and the ankle to handle stress well. So the knee may take on an awful lot of stress. Okay, so what we're doing here now is we're understanding what are the kind of things that the limb needs to express to handle stress well. Because if these features aren't cooperating very well, then we may see excessive stress in the knee. And there was a question there, how do we check the hamstrings able to express isometrically? We're going to go through a very, very simple, a very general kind of isometric kind of load test. So what we'll do is we'll bypass this slide here because we spoke about the hamstrings a bit. So what this is here is a very general isometric capacity test for the hamstrings. Now, when we look at the hamstrings, we need to consider, if I just go back to this slide just for a second, that the hamstrings will extend the hip via more of a posterior rotation of the pelvis. So the hamstrings will insert up into the ischial tuberosities, but they'll also work to flex the knee. Okay, so we need to consider how the hamstrings are interacting with the pelvis as well. So what we have here is we have the client on their back with the foot and the heel connected onto a chair. So we have a 90-degree motion at the hip. We have a 90-degree motion at the knee, for example, here, okay? So you want the knee to remain, or the hip to remain at 90 degrees. You want the knee to remain at 90 degrees. So what we're trying to do here is we're trying to understand, can the hamstring isometrically contract without the lumbar extensors expressing too much anti-gravity activity, without the anti-gravity tissues of the spine, right, here, without these posterior tissues helping, right? Because very, very often when you're checking the capacity of the hamstrings to isometrically contract, many individuals will extend their spine to help lift the pelvis off the ground. So the way you're going to do this is a very good insight into how the hamstrings can isometrically behave, is you're going to have the client flex the opposite limb towards the chest, because what this does is it allows for an easier capacity to posteriorly rotate the pelvis. So when you flex this opposite hip towards the chest, that's going to pull and bias the entire pelvis towards a posterior tilt, a posterior rotation. you're going to have the client try to flatten the lower back into the table, and maintain that position. You're going to ask them to gently build pressure down through the heel and continue to build that pressure, and ask them to scoop the pelvis up off the table. So you're telling them as if this is their spine and this is their glute. What you want them to do is scoop the glute off the table without the back coming up into too much extension. And what you'll find in a lot of clients, they might not be even able to do this. And when they get into this position, they're unable to maintain that pelvis hovering off the table for at least 2 inches for a certain period of time. And typically for us, we want the individual to maintain this position for at least 1 minute to give us the insight that the hamstrings can express the capacity to handle stress very, very well. Okay. So this is looking at it's obviously it's giving us an insight into the capacity of the hamstring knee attachment to handle stress isometrically, but it's giving us the further insight into how well the proximal portion of the hamstring can handle stress by allowing the client and seeing if the client can maintain that posterior rotation of the pelvis. So whether you have the capacity to do this now, or whether you're going to wait till after the webinar, if you try this on the ground, make sure that you set up in a position where the hip is flexed 90 degrees, the knee is flexed at about 90 degrees. Obviously, it's a little bit more flex here because we probably need to because we've obviously lifted the pelvis up 2 inches here. But make sure you flex the opposite limb towards the chest to facilitate that posterior rotation of the pelvis. We're flattening that lumbar spine into the table, and we can do that by having the client take a gentle breath in and then exhaling. As they exhale, they naturally flex the rib cage, which will naturally allow for the lower part of the posterior spine to flatten into the table. They're maintaining that position. As they maintain that, they're building pressure down through the heel and continuing to build that pressure until they can actually scoop the pelvis up off the table. And what you'll find in a lot of clients, they will be unable to do this. And if they are able to get into that position, they'll tend to hold their breath, or they'll tend not to be able to maintain it for a long period of time. Because when people are doing this type of test, they're typically extending through their spine. So they're using their spinal tissues to help extend the hip as opposed to the actual hamstrings. So we need to be very specific with how we're actually checking the capacity of the hamstrings to handle stress and handle load isometrically. Now, this is obviously looking at the hamstring at a certain angle of the hip. We can further check, especially in individuals that are maybe a bit more athletic or that can handle more stress, or maybe that get stress when they're moving in different kinds of environments. Maybe they don't have pain when they're at rest, but maybe they have more pain when they're moving. Maybe we need to change the angle of the femur. Instead of having it at 90 degrees, we need to move it towards maybe 60 degrees, but still maintain the knee at 90 degrees. Now, this is just one test you can do. This is one of many that we will use. But generally, we're combining a test like this with the range of motion of the hip, the knee, and the foot and the ankle to get an idea of how the whole limb is handling stress. But the main thing I want you to consider here is how the muscle architecture of the limb will give us an insight into how the muscles are designed to behave, right? Because if you think about it, the glute is not designed to behave the same way as the calf, right? Because if that were the case, then we wouldn't really have a lot of adaptability in the body. For our body to be adaptable, to share stress well, and to make sure that the knee isn't getting hit with all the stress, we need to make sure that the muscles can take on different roles, right? So generally we want the distal tissues to express more isometric behavior because they're in contact with the environment. And that capacity for the distal tissues to take on more isometric behavior gives these structures proximally the chance to be more movable and adaptable. So many times, when we have clients with knee pain, we may look at the hip and we may think that the hip is weak, or we might give them glute bridges, or we might give them, kind of hip strengthening exercises. But what you'll find many times is that the individuals lose the capacity of the distal tissues to express good isometric behavior. So what has to happen now as a compensation is that the glute needs to take on a role that it shouldn't have to take on. So now the glute is actually acting like the calf when it shouldn't. So now you have a muscle that should be able to lengthen and shorten, but now it's contracting isometrically to try and manage the pressure moving through the limb. And if that's being done over and over again, when you test the hip, for example, what you might think is weakness is actually fatigue. Right? So the glute is actually fatigued because it's doing a job that it shouldn't have to do for a sustained period of time. And that may lead us down a path that we don't want to go down. All right. So very, very often we're looking at how well the distal tissues, the calf, the hamstring, can isometrically contract to allow for a sharing of forces across the knee. So let's say, for example, we have an individual with limitations in knee flexion. So what we'll typically use, and you can look at this two ways. So when you have a client in supine and you're looking at their ability to get their heel all the way to their glute, that's going to give you a very good insight into how well that screw home mechanism can unload. So you want that tibia to be able to internally rotate as they flex the tibia. Now, what obviously needs to happen here is that the distal portion of the rectus femoris and the quadriceps need to be able to eccentrically contract, right, or lengthen. Okay, they need to be able to relax, because if these muscles here are always holding a lot of concentric activity, then that might reduce the capacity of the tibia to be able to internally rotate. And so, like if this is 90 degrees here, okay, I'm not sure if you can see that arrow, but let me show you on here, for example. So on this knee model, so as the knee moves from 20 degrees, I'll show you here. So when the knee is fully extended and we move to 20 degrees, 30 degrees of flexion, that's when the knee should begin to internally rotate. But if we have a lot of activity in the quad, for example, if the quad is very tight, then maybe that tibia doesn't begin to internally rotate and we hit the end range too soon because we're not able to fully internally rotate that tibia. Now that might be a joint issue, or it could be an issue with the quad. So what you can also do as well is you can measure that in prone. So typically when an individual is limited in supine, they can't get the heel back to the bum. Maybe it's more of a joint issue where we might need to do some kind of specific manual joint mobilizations of the tibia. But if they're more limited in prone, for example, not supine, we get them onto the stomach and we try bend their knee back. If they feel more limitations there, then maybe it's the quadricep that is expressing too much muscle activity, all right, and not enabling the knee to fully flex, not enabling the tibia to fully internally rotate. So we need to consider the entire limb, for example. So when we're looking at knee pain, for example, we need to understand and consider, can the tibia fully internally rotate? Can the hip fully internally rotate, right? Because if the hip can't fully internally rotate, then that's going to influence how forces are being moved down from the hip into the knee. And if the hip can't fully internally rotate, then maybe the knee will have to move more. So that's when you might see that dynamic valgus of the knee, because the hip can't fully internally rotate. So it needs to steal more range of motion from the knee. Okay. So if somebody has, excessive stress through the knee, for example, maybe we actually need to do more work around the hip to make sure the hip can move well, so the knee is not getting too much pressure. We need to understand, can the quads and the rectus femoris unload their anti-gravity function to actually allow for the knee to unload? Can the hamstrings handle stress well? And we can use the very simple test that we did there for the hamstring load capacity in the previous slide. And then we can look at the gastroc and soleus's capacity to handle load as well. So the capacity, remember, the gastrocnemius is another biarticular tissue. So that biarticular tissue is designed to be able to transport forces or shear forces from the foot and the ankle up through the knee proximally. So the gastroc allows us to shear forces from the foot proximally. So if the gastroc and the soleus, particularly the gastroc, if that can handle stress well and behave isometrically, then potentially we don't have the ability to share forces across that lower limb, and then maybe the knee may be overloaded. So remember, what we're looking at here is we're looking at the capacities of the limb to be able to handle stress, because when we have pain in the knee, and it doesn't matter if it's anterior knee pain, if it's medial knee pain, lateral knee pain, we're looking at capacities. Can the knee internally rotate? Obviously, if we're looking at knee flexion, but sometimes if someone's limited in knee extension, we need to consider, can the tibia externally rotate? Okay, so we need to consider all these different things, but we need to understand that the limb as a whole will need to take on different types of behaviors. So the hip, the knee, and the ankle and the foot aren't going to do the same thing. They will behave differently to make sure that forces can transport over broader surface areas. So just like that orchestra example I used at the beginning, you know, if you have an orchestra and everyone's playing the violin, it might be a very boring orchestra, but if you have someone who's playing the violin, someone who's playing the cello, someone who's playing the trumpet, someone who's playing different instruments, that might allow for a better sound. You know, it might allow for a better symphony because there's more cooperation. Everyone has a different role. Everyone plays a different instrument. It's the same thing with the lower limb. If everything did the same exact thing across the lower limb, it wouldn't be a very adaptable lower limb, and certain areas will get hit with the same stress over and over again, as opposed to being shared over broad surface areas. So when we're treating the knee, for example, we need to consider that, you know, if we're trying to, for example, improve the capacity of the knee to, let's say, for example, so how do we check the gastroc isometric capacity? So there's many ways you can check the gastroc isometric capacity. What we would typically do first is we would check the capacity of the foot and the ankle to move through dorsiflexion, because if you have a lack of dorsiflexion, then typically what's happening is the gastroc is actually expressing too much concentric activity. Okay, so that tells you right there and then that potentially if the gastroc is actually expressing more concentric activity, it may not be able to bias more eccentric activity. Okay, so that's information there straight away for us, that we need to disrupt that kind of concentric behavior and restore more eccentric isometric capacity of the foot and the ankle. And that's where we're going to be, maybe instead of using the heel to handle stress, what we can do is we can actually start to put that pressure through the metatarsal heads. So instead of using a chair here, what I can use is I can use maybe a yoga block. I can use a medicine ball. I can use a foam roller. I can take the metatarsal heads on top of the foam roller, and I can have the client build pressure through the metatarsal heads to basically scoop the pelvis off the table from there, and see how well capable the distal tissues are at handling stress. So we can move from the heel to the forefoot in that example. But like this type of test on its own won't give you all the information that you need to treat the knee. It's just one thing. So if the individual can't handle stress with this, it's just one limitation that we may need to improve for that individual to ensure that they can actually share stress well across the limb as a whole. So the reason why I took the picture from Google, and many of us might think that, you know, a neutral foot is a good thing, a pronated foot is a bad thing, and a supinated foot is a bad thing, but that's not the case. That's why I have here that these are all wrong in how they describe these different positions, because your foot needs to be able to pronate, but the problem might arise when your foot can only pronate, when it can't do anything else. So if you have a foot that's always kind of in a pronated position and it can't move into supination, that's when you may have a problem. Likewise, if you have a foot that's always in a supinated position, meaning that the arch is always high, then that can pose a problem as well, because that's a reflection that the foot doesn't have good adaptability. And if you have a foot that's always biasing a certain kind of activity, whether it's pronated or supinated, then that means that the tissues that go from distal to proximal, particularly the gastrocnemius and the soleus, that means that they may also be expressing only one kind of behavior. And remember, we don't want the muscles to only express one kind of behavior. We want the muscles to express different kinds of behavior. And that allows for adaptability. That allows for your limb as a whole to dissipate stress and share stress over broader surface areas. And that will allow the knee to become less overloaded with stress. So many times what we see with practitioners is that they're, let's say, if you have limitations in the knee, for example, and you might do some mobilizations at the tibia, and you may be able to improve some knee flexion by getting some better tibial internal rotation. But what if that tibial internal rotation what if that lack of tibial internal rotation is there because let's say the gastroc can't contract isometrically, and the individual has to move into knee extension to feel stable, or if the quads are constantly expressing too much concentric activity, and the knee is always moving towards extension, they can't bend the knee. So when you do rotation mobilizations of the tibia, it may not hold because you haven't trained the muscles to be able to allow for that tibial internal rotation. So it's about looking at how the muscles behave, how the joints behave, but also how the nervous system interacts with the limb as a whole. So if the nervous system doesn't trust the limb as a whole to handle a stress, you're probably going to move those joints into a closed packed position, right? So the knee might go into full extension because it's a closed packed position. That's a position where there's less movement around the knee, but it's not going to be good if you're trying to walk around the real world with a fully extended knee, is it? It's not going to allow for stress to be shared across the knee. So when we can consider how the nervous system, the anatomy, and the foot all work together, then we can allow for much better treatment interventions for the individual. And obviously this lecture is more so designed to give us an insight into the concepts around the knee and limitations and movement around the knee, looking at muscle behaviors, muscle features, joint features, neurological features. This can allow us to construct much better rehab interventions. So from a treatment standpoint, we would have knee pain. So when I try isometric, so this is a question. When I try isometrics of the hamstrings, often patient with knee pain feels sudden catch and spasms of the hands. Could I consider it as a lack of hamstring? Yes. So if the hamstring isn't able to maintain that position, okay, and they have if they have an excessive cramping or excessive pain or like a fatiguing of the hamstrings, that's a representation that the hamstrings cannot express good quality isometric function. So what I see an awful lot of times in clinic is that they may not be able to get into the position, or when they're in that position, their hamstrings cramp very, very quickly. Okay, and so that's something that we need to work on. Okay, so from a rehabilitation standpoint, it may not be a case where you're driving that heel into the chair and you're coming up all the way, but you're driving that heel very, very slightly, and instead of actually lifting the pelvis up, you're gently unweighting it. Okay, and when you gently unweight it, it still gets the hamstrings to contract, but it does so in a way that they can tolerate it. What you also might need to consider as well is that when someone does this, and I'll bring this back here. When someone does this, and you can look at this in your clients as well. I see this a lot in knee pain clients. So when they get into this position, and you ask them to build pressure down to the heel, what you'll see is the foot externally rotate, or the tibia externally rotate. And what that tells you is that they're using a strategy of external rotation of the tibia to contract the hamstring, whereas we want the toes to stay facing forward. So by the client doing that without you giving them too many cues, that's telling you that they're probably biasing more external rotation of the tibia, right? And so what you might need to do from a treatment perspective is when they're doing this, and this is just one of many things that you can do. This is not the only thing they'll do, but you might need to manually internally rotate their tibia into internal rotation, their foot into internal rotation. So if I have the foot here, for example, and that knee is, let me see, make sure I can do this. That knee is, let's say this is the position. You might need to manually internally rotate that foot and then have them drive force through the inner portion of the calcaneus to build pressure, right? Because very, very often what you'll find is that clients will cheat by externally rotating the tibia, because when they do that, they'll contract more the lateral portion of the hamstring, the biceps femoris. But if you manually move their tibia into internal rotation, have them do it, they'll typically really, really struggle. So the medial portion of the hamstrings, the semimembranosus, the semitendinosus, can't contract very well, right? So use as an assessment. How does their tibia move when you just ask them to do this? Don't say, I want you to keep your toes straight, but just do it and see what they do. See if they can just do it and see what kind of behaviors they'll do. People will do funky things, but it'll give you a lot of information about what kind of strategies they're using. So if they externally rotate the tibia, then that probably means that they might not be able to internally rotate the tibia, right? Because in this position of 90 degrees of knee flexion, we want that shin to either remain forward or internally rotate slightly, or at least try to internally rotate. But very, very often you'll see the client externally rotate the tibia. You'll probably even see the whole limb externally rotate. You'll probably see the femur externally rotate as well. Okay. But that was a good question. Okay. Because we can see, like, I know this is a general low capacity test, but there's many, many things you can do in this position. We can even internally rotate the femur as a whole and internally rotate the tibia to allow for all the medial structures to take on more stress. And I will do a lot of that with clients with, lateral knee pain a lot of the times. So from a treatment standpoint, again, obviously we don't have much time to go through this, but we have kind of key things that we're going to go through. Early on, we're looking at how we can restore dissociation. And dissociation is essentially how well, joint segments can move in opposing directions. So can the tibia internally rotate while the femur stays externally rotated? Right? If you're trying to internally rotate the tibia and the femur goes with it, then that's a sign that they probably can't dissociate that tibia from the femur. Right? Probably the best example of lack of dissociation is in the spine, where you ask somebody to turn their head, right? You ask somebody to turn their neck to the right, and all of a sudden you see this where the whole spine goes with them. You see the torso, the ribcage turn with them as well. So they're unable to dissociate the head from the torso. Okay? So you'll see that in the hip, you'll see that in the foot and the ankle a lot of the times. And we might need to restore that. So there's certain treatments that we will use that are consistent across many clients, but if we can't do that actively, we'll have to use more kind of local manual feedback strategies, what we term local feedback strategies. Then we're moving into what we call overcoming and yielding strategies, where we're looking at loading the muscles in a certain way. We're looking at restoring variability in the contractile behavior of the structure. So if the quadriceps, for example, are expressing a lot of east or concentric activity, we're going to try and kind of load them in a way, treat them in a way that tries to restore the capacity of the quads to express more eccentric behavior. And that doesn't mean just stretching the quads. That means using very specific techniques to kind of unload the quads. And we're doing that with more sub-maximal load sharing qualities, okay? And then we're moving through this step-by-step process. So the way we treat an individual will be very much step-by-step. And sometimes the client might not need these local feedback strategies. So if a client has lack of tibial internal rotation, for example, one simple dissociation strategy, like this, for example, if we use even this as a treatment, for example, if we allow or ask the client to internally rotate their tibia in this scenario and have them build tension down through the medial portion of the heel and scoop the pelvis up and have them work on that and have them try to experience tension through the hamstrings and make sure they can feel the hamstrings working hard, then that can restore that capacity of the tibia to internally rotate, while you're also getting the hamstrings to restore their isometric activity as well. I see that a lot in clients, especially elderly clients that that can't do a lot of fancy exercises. This is a very easy one for them to do. So that's one example. But maybe, for example, for somebody that has real sensitive knee, for example, they might need more manual strategies to restore that tibial internal rotation, and we will do that then. Right, but we'll always try active first and then try more manual, more local active strategies. Okay. And then we'll move through this step-by-step process. And that's exactly what we do on our courses. So this is just looking at the knee, for example. Now, on our courses, what we want to try and do is make sure that we equip everyone with a much better understanding of how they can actually view how muscles, joints, and the nervous system interact with each other. And what that does, it allows you to know exactly what you're going to do or try with the client straight away. So if you have a client that's coming in with knee pain later in the day, for example, you know exactly what you're going to try and check, because you know what kind of behavior the muscles need to express to be able to handle stress well and share forces well. That's really the main thing that we're looking to improve, is how an individual can share forces across the entire lower limb, so that forces aren't always being magnified around the knee as a whole. Because typically the knee is the victim as opposed to the culprit, right? So in terms of down-regulating the quadriceps, what we might need to do in this scenario, so if you think of this scenario here, for example, sometimes you'll have clients that, you know, they have such high amounts of knee pain that they're unable to get into this position here. So what we might need to do is we might actually have to kind of bring the knee maybe towards less degrees of knee flexion, because in order to get into this position here, what the rec fem, the quadriceps, have to do distally around the knee, they have to be able to unload. But they can't do that. We may have to start towards more extension. So maybe we might bring the tibia at this kind of angle, for example, and then work through the same thing. But typically, you know, one way that we could down-regulate the quadriceps, for example, is by extending the hip. So moving the femur towards more extension. So we move away from a deeper angle of hip flexion towards more hip extension, because that will force the quadriceps to unload their anti-gravity function. But we're going to slowly move into that position. Okay. Other ways we can do it is we can do it manually as well. So we may have to get the clients into a prone position, and what we'll typically do a lot of the times is manually kind of position their tibia into internal rotation as we move the knee back into flexion, because that will allow for the quadriceps to have to down-regulate, because the muscles will down-regulate when they have to lengthen. They'll have to. If they don't down-regulate, they don't lengthen. Okay? So down-regulation is typically associated with less muscle activity, right? Where we're producing less force into the tissue from a top-down standpoint. So less concentric behavior would be down-regulation of a muscle tissue. And so we may have to kind of use more kind of low thresholds, kind of contractions through the tibia, but we need to maintain the tibia into internal rotation as we move it further and further into knee flexion with the client in prone. So, you know, it's hard to, you know, give you a quick way to do that, but it will depend on the client's level of tolerance. So we'll need to probably use, in a client that is very sensitive around the knee, we may have to use more manual strategies, but we'll always check actively first. So this may be one example of an active strategy. If they're able to do this, like very often I find that a client has, you know, limited, let's say they're probably about, you know, 2 fist widths away from the glute, for example. So you're checking the knee flexion, for example. Where is that? Just find that picture there. So this test here. So maybe like they're 2 fist widths away from the glute, so 20 centimeters. Fist width is about 10 centimeters. So that means that their quadriceps can then regulate a certain extent, but they feel that pain at the end range of knee flexion. Okay, so in that scenario, they'll probably be able to get into this position here quite fine. But then you want to really kind of stress the hamstrings in this position and really make sure the tibia can internally rotate. Because in this position, the quads aren't going to be doing much work. Because remember, the quads and the rec fem particularly will flex the hip and it will extend the knee. And you're trying to do the opposite with this. You're trying to extend the hip and you're trying to flex the knee. So this strategy as a whole will help to down-regulate the quadriceps. I just had a client in just before this webinar who had a lot of impingement in the anterior portion of the hip with a lot of concentric activity of the quadricep. And this strategy here was able to really improve his symptoms before we did a lot more kind of focus work. So sometimes if you're trying to improve someone's movement by doing a lot of fancy things locally without thinking about how we globally share stress, then you can create more confusion for yourself. Okay, so there's lots of ways we can kind of consider this simple positional drill here, okay? And it can serve as a platform to downregulate the quadriceps. So that's me. Does anybody have any other questions from the webinar? So really, the main thing we wanted to try and get across there is that knee pain is not only a knee issue. We need to consider how everything across the lower limb is moving. When we can consider how everything across the lower limb is moving, and we find limitations, and we improve those limitations, then we can reduce excessive pressure and load through certain parts of the body, particularly the knee in this case. But in order to understand how everything is cooperating, we need to understand the general behavior and the features of muscles. We need to understand the coupling behavior between joint segments. We need to understand how the nervous system interacts with the lower limb as a whole. Okay, so it might be a very different way of appreciating how the lower limb is behaving. I'm sure you've noticed that I use that word behavior an awful lot because our body is very dynamic. So muscles don't get stuck in a certain position. They express a certain behavior, right? So, you know, when people use that term long versus short, they might say, oh, your quadriceps are short. I don't view them as short. I view them as behaving more so concentrically, right? When people say your hamstrings are long, for example, I don't view them as being long. I view them as maybe behaving eccentrically, and maybe the hamstrings are unable to contract concentrically or isometrically, right? So when we can shift our focus from a long versus short type of mindset to more of behavior, it actually opens up a lot more room for different kinds of treatment interventions. So question again, so instead of passively stretching the quads, we were asking you to maintain internal rotation of the tibia and active knee flexion. That's one way to do it. Exactly. Now that doesn't mean that you don't have to stretch the quads. You can certainly stretch the quads, but by stretching the quads, you're not really, so let's say you have a quadricep muscle that's really, really tight, and you do a prone knee bend test and they're really, really tight. You stretch the quads and they might feel a little bit better. You haven't actually retrained that quad how to better manage forces. So that quad might just go back into that concentric behavior. So what we might need to do is we might need to train that quad to contract eccentrically by getting them into knee flexion, and then by actually restoring the capacity of the muscle on the other side to contract more concentrically, to take on more workload, more stress, okay? To actually give the quad a chance to express more eccentric behavior. Okay, so that's just one way of doing it. It's less about trying to find one thing that fixes things, and more about trying to understand what kind of sequence that we need to work in. Okay, so I've no problem with people passively stretching the quads, but maybe if you passively stretch the quads, then you come back to being able to maintain internal rotation of the tibia and move towards active knee flexion, right? And then you might progress. You might progress from there to maybe extend the hip, right? So question, how much time do you expect changes upon training? So when it comes to changes, you have to keep rechecking, right? So after you do something like this, if you recheck and they have an easier time flexing the knee, then maybe they just might need to work on that strategy. But if it's not a case of, I can tell you this is going to be 3 weeks or 4 weeks or very, very quickly. We need to restore the capacities of these structures to handle stress. And when we can restore the capacities of the structures to handle stress, then we can theorize that this will reduce the excessive stress in the knee. So I will always tell clients that we're not necessarily trying to fix the knee pain, but we're trying to get everything else around the knee to handle stress much better. So the knee doesn't have to take on too much excessive workload, okay? And that's a process. So that's where the assessment comes into play. So if you assess somebody and they have really limited knee flexion, after you do an intervention, you need to recheck the knee flexion, see how it responded. You need to make sure first and foremost that you actually didn't make them worse, okay? And then if, for example, they feel the same after doing something like this, then what you might need to do is you might actually have to challenge them further. So maybe the stimulus from the exercise wasn't enough of a challenge to actually allow the nervous system to change what's happening throughout the knee. Right? So that's when an individual might need to move from less hip flexion to more from more hip flexion to less hip flexion. So we bring the heel down towards onto a lower block surface, but and still drive that force through the heel. Okay, because that's going to challenge a lot more of the hamstring. It's going to challenge a lot more of the hip, but we would still maintain that knee at 90 degrees, because at 90 degrees of knee flexion, that's when we're going to have the greatest capacity to rotate and couple the knee. That's when we're going to have the easiest ability to rotate here, right? But sometimes if someone's really limited in hip flexion, we may need to start in a little bit more knee extension, right? So when they go from extension to 20 to 30 degrees, we may have to bring them to 40 degrees of knee flexion and then work on getting that tibia to internally rotate and then slowly move further and further. Right? That's one example of how we might need to work with that. And then it's a process of allowing the client to understand that, we need to get these features, these capacities to be able to handle stress much better. And when we can do that, it will reduce the excessive stress on the knee. But until we actually restore these capacities to handle stress, we're still not sharing load across the knee, and potentially that pressure is always being distributed through a certain part of the knee. So maybe the anterior knee will continue to get stressed until we can actually get other areas of the limb to handle stress. So you're restoring variability across the lower limb as a whole. Okay, so how much time would you expect the changes to happen? It depends on the client. It depends on their initial assessment. It depends on their response to the intervention. Sometimes clients might be able to experience significant improvements in their symptoms after one exercise. Sometimes client might need to take more baby steps. So for example, like if this was a client, let's say I have two clients, right? They both have very, very similar issues, but client one has a history of 3 different surgeries around the knee. And they also have a history of like 5 ankle sprains at the ankle. But the second client only experienced a gradual onset of knee pain. Who do you think is going to respond much quicker? Probably client number 2 with a less extensive past injury history at the knee and at the lower limb. Because maybe if we have an individual with a lot of past injuries at the limb, for example, that's going to make their nervous system maybe not trust that limb to handle stress. So that's when we have to kind of take baby steps to prove to their nervous system that their limb can handle stress very well, versus client number 2 with that just gradually got a little bit of knee pain after going for a run, for example. Maybe it's a case where we just have to, give them a certain exercise to prove to the nervous system that that limb can handle stress very well. Okay, does that make sense? And if it doesn't, you can ask me another question. Does anybody else have any other questions? So hopefully that was insightful for a lot of you. It's a different way of viewing how we approach the lower limb, but this is, at least from our perspective, this is the way that a lot of rehab, a lot of treatment is going, is looking at not how we can just fix symptoms. That's important, and we go through that a lot in our courses, but how can we actually understand how the lower limb as a whole should behave to handle stress well, and then looking more locally. So remember, looking at the global versus the local behaviors. So globally throughout the limb, it needs to take on certain behaviors to handle stress. But in an individual where they have more kind of local pain around the knee, for example, we need to look a bit more focally at how the femur and the tibia are working with each other, how the femur and the pelvis are working with each other, how the tibia and the foot and the environment are all interacting. Okay, so it just depends on the client's situation, their assessment, and having that framework in place. So what we go through on our courses is exactly that, developing that framework, going through lots of different assessment strategies to identify how the knee is handling stress, how the limb as a whole is handling stress, and then understanding what do we need to do to restore the capacity of the limb and the knee to be able to share stress well, so that local areas are potentially not taking on too much stress and expressing irritation or too much sensitivity that may be expressed through a pain experience. Okay, so hopefully that made a little bit of sense. Okay, do we have any other questions, or do we want to jump to the other PowerPoint? Dr. Sumaya.
I think it was an amazing webinar, very insightful, a lot of new, and to think of it, this is just a webinar. I can't imagine how in depth the course is going to be. You know, it's really going to change the whole perspective on how we've been assessing and treating patients with knee pain. And I think all the attendees who are here with me would agree with the same.
Yeah.
Yeah.
So
we can move to the next.
One quick question there, Samia. So there was a question there: is it better to start with closed kinetic chain exercises to correct for lack of rotation? What you want to do with closed kinetic chain exercises when you're trying to improve rotation is you need to make sure that you're driving that force through the heel. Because, for example, if you were to put the forefoot in contact with something, it makes it very difficult to rotate the tibia. So as long as you have the heel in contact first, and then you can use that as a lever to rotate the tibia while you're getting low through the limb as well. But if you go too soon to the forefoot, then it's going to be more difficult to restore better rotation throughout the tibia. Okay, so that's just an important point to consider there. Perfect. So we can move on to the next PowerPoint. So, you guys, just to tell you before we can move into this PowerPoint, again, the main kind of reason we wanted to share these webinars is just to give you a very kind of a very quick and general insight into how we approach the assessments, exactly what we go through on our courses, to make this information very simple to understand and to really give you a much more, what we say, robust, a much more complete assessment and treatment framework, so that you know how to, you always have that step-by-step process in place. So our goal with how we approach treatment is to make sure that you always know what you need to do to help someone. You always have something there that you can use to help someone, because we have that step-by-step treatment or assessment treatment process. And what we want to do with these courses as well, as you can see here, is that we want to, do you want me to go through this, or do you want to go through it, Dr. Sumaya?
I think we can proceed, and then I'll probably talk at the end regarding the...
Yeah, so we have the layout of these courses is that we have two levels. We have, obviously, we're looking to share with you the IKN diploma, which gives you access to the IKN level 1 and the IKN level 2 coursework. At the moment, we have a lot of pre-recorded information online. So we have our whole course in an online format. So you'll get full access to that. But what we're also giving with this is these kind of individual webinars where we're going to go through more so case studies. So looking at individual case study scenarios, where what we would do with an individual client from the beginning of the assessment process to the end of treatment, what exactly we do with each individual client. So it's not just going to be you're only watching pre-recorded information, you don't get anything else. You're getting lots of these little individual webinars with lots of opportunities to ask questions as well. And we're also going to follow it up by having a 2-day in-person course. So one day for the level 1, in-person day for the level 1, IKN level 1 content, and the level 2 content. So 2 days in total where we're going to work together in person and go through all of this information practically. So we're going to work through what we would look at in certain case scenarios, how it looks practically hands-on, and it will really bring all this information together and hopefully equip you with a lot of good information that you can use within your own clinics, right? So I just wanted to make it known that it's not just you watching pre-recorded information. We're going to support you the entire way through, because we ultimately want you to be able to be certified in using this information, understand the information well, so that you can be recognized as more of an IKN therapist, because we have lots of those therapists, especially over in the US at the moment, who are using this this content, this material, with very good success. Do you want to jump in there, Dr. Sumaya?
Yes, thank you so much, Dr. Ryan. We have come up with this format in collaboration with IKN. We wanted to ensure that the participants, due to COVID, we are not able to organize in-person courses at the moment. But at the same time, we wanted to make sure that the courses are at par. You have a proper in-person course as well, and you do not miss out on much of information. Given that, as Dr. Ryan has said, that you're going to have over 48 hours of online study material, it's a combination of pre-recorded lectures, it's a combination of all that, and in-person course, as well as live sessions with Dr. Ryan, where you can, address to all your concerns and ask him questions. Other than that, there is a support group. Dr. Ryan can personally assist you, help you. He'll answer all your questions. And what we are doing is the first batch has successfully been, it started, it was completely full. Now we've come up with a second batch at the moment that's going to start on the 13th of July. And this will be the last batch to we're going to combine the first and second batch so that they can attend the in-person course together. And this is the last webinar where you can avail an offer. We're coming up with an offer for the participants of this batch who could use, and if you can see, we've put out the offer at the moment. It has a link that redirects you, and you just need to pay 500 dirhams to register for the course and pay the later, asking us about the split payment. I think Debbie would be of great help to assist you with that. She'll let you know how to go ahead with it. This is exactly how we have come up with it. So there's level 1, level 2, as Dr. Ryan said. Each level is for 4 weeks. They're going to be total 8 modules for each level, and then an in-person course. And plus, you're going to have Zoom sessions with Dr. Ryan every 2 weeks. I think it's an amazing opportunity for anyone who's interested in the course and who's found this webinar, which is just, I guess, a tip on the iceberg. It's just, I think you've not covered even 10% of what actually the course is about. But I think that itself was so insightful. So I can imagine how the entire course is going to change the whole dynamics, how we look at things, and how we. So that's what we call this course. It forces you to think out of the box, and it is the missing link in your treatment protocol. Because I've personally applied this on my patients and I've seen amazing results, miraculous results. And I would like to thank Dr. Ryan for that. So guys, whoever is interested, please go ahead to the offers and take a look, book your slot, because this is the last batch for this time, for this in-person course. This is the last time that we're going to come up with any webinar or a batch to move forward. So the first batch is successfully moving, and I think they're going to have their first live session with Dr. Ryan soon. Mm-hmm. So we'll join you guys as well. You'll not miss much. You'll not miss anything, in fact.
No, nothing.
Yeah. Anyone has any questions, any queries, we're always here. You can reach out to us, and we'll be happy to assist you. Thank you all again.
Perfect. Yeah, thanks, guys.
I would just like to request you all to please support us on the social media and give us a thumbs up, a like, if you want to stay updated with all our information. We are going to come up with lots of free webinars, not just with IKN, with our other courses as well, but definitely with IKN as well. And if you're interested, please give us a thumbs up and follow us so that you kind of do not miss out on any of this free content. Dr. Ryan, would you like to add in something?
No, that's it. I just want to say thank you to everyone for sharing your time to listen in. Hopefully you found the information insightful. Like Dr. Sumaya said, it's just the tip of the iceberg there, but what we want to go through on our course is how to practically integrate all this information. And we'll provide as much support that's needed. We'll do more Zoom sessions and webinars like this going forward with the group that sign up to level 1, level 2. So we're very much dedicated to helping everyone kind of learn this information as well as they possibly can to ultimately, improve their treatment outcomes. So I just want to say thanks to those of you who stayed on for the entire webinar, that are obviously, curious about this and have the intention of improving your own treatment approaches. So I just want to thank you for sharing your time, and hopefully I'll see you in a course soon.
Yeah, I would also like to mention that the recording of this webinar will be put up on our website, or if you're interested to watch it again, or learn better or share it with your friends, reach out to us and we'll share the link with you. We'll let you know how to go about it.
Perfect.
Right, I think, yeah, thank you. Thank you, everyone.
Thank you.
We'll wrap it up here.
Perfect.
Yeah. It's on your end, Dr.
It's on my end, sorry. Thank you very much. Bye-bye. Bye-bye.